There we go.
Thank you so much for coming to listen to our talk. I'm here with Priscilla, Kristen, and Grace, and we're here to kind of talk about some of the research that we did over the summer at Summer ICERM at Brown University under the amazing guidance of Dr. Sulyok and Dr. Stevenson, along with Austin and Matthew, who are our grad TAs. And the focus of our research project was basically mathematically modeling Clostridioides difficile transmission in long-term care facilities. Before I kind of go into the model itself, I want to provide a bit of background of what the bacteria is. So Clostridioides difficile, it's quite a mouthful, so I'll just be referring to it as C. diff from now on. But it mainly spreads through the fecal-oral route, and it mainly transfers through spores. So an individual who has been infected by the bacteria may leave some spores on the surface, and then subsequently another individual may pick them up. And once it's ingested, it becomes active in your gut again. A lot of individuals, if you have a healthy immune system, you're able to combat the bacteria infection. However, if you're of older age, have a weaker immune system, or on antibiotics, you're more susceptible to being infected and have symptoms including diarrhea and stomach tenderness. So the focus of our mathematical model is in the context of long-term care facilities. This is quite a broad term that covers a bunch of different types of facilities. You may have heard of independent living or nursing homes, but the general idea of all these facilities is to provide medical and personal care to support daily life activities. So this might be toileting or dressing. And for our specific model, we decided to focus on assisted living because individuals in these facilities tend to be more mobile. And as a result, we can see interactions with resident to resident and also resident to environment, which were two things that we were very interested in. And the average stay was roughly 20.3 months in assisted living care facilities. So just to reiterate again, the main goals was to build an ODE model to help us understand how this bacteria spread in long-term care facilities, and also analyze our model to propose different strategies and also different programs that could be implemented to help nursing staff across the US.
Before getting into our model itself, these are our resident and pathogen classes. The first four are our resident classes: S for susceptible, C for colonized, which is also asymptomatically infected, D for diseased, which is symptomatically infected, and Q for quarantined. And then we have pH for our spore density in high traffic areas. We deem high traffic areas to be areas where there's a lot of interaction, for example, common rooms and cafeterias. And then PL for spore density in low traffic areas, which are conversely areas with little interaction, such as a resident's private room and private bathroom. And then we also have PW, which is our spore density on healthcare workers' hands, since we deem healthcare workers to be a vector for disease transmission. Here is our model. At the top, you can see our resident classes. One thing I want to note is that going into S&C, we have our admission rates, which are AS and AC. And then going out of each class, we have our discharge rates, K for S and C, and then KD for D and Q. One thing that you can see a lot in this is that there's solid lines and also dashed lines. The solid lines indicate actual movement between classes, so a resident actually moving from one class to another, whereas dashed lines describe the interaction between classes. For example, the dashed line from D to S indicates a susceptible person interacting with a diseased person, and then that contributes to the susceptible person actually moving into the colonized class. And then lastly, what I'm gonna point out is there's the three pathogen classes in the center, and you can see that there's a double-sided arrow going between PW and pH and PW and PL. And this will be described by our Heaviside function, which I will talk about in the equations. So here are our model equations, the first four being for our resident classes, and then the last three being for our pathogen classes. At the first two equations, you can see that there's an AS attached to a delta Tn and then an AC attached to a delta Tn. As I mentioned before, the AS and AC describe the admission rates. And then the delta T in is our total discharge from the model. And we use this to make sure that the model is always at full capacity. And then lastly, in the last three equations, there's a T1 and T2, which in the next slide, you can see more. So they're highlighted here, and basically the T1 and T2 describe a net transfer of spores, and it's one directional. So whichever spore class has the higher spore density, that will transfer onto the spore class with the lower spore density. It's kind of like a light switch where at each time step, it's either going to be for T1, a positive pH or a negative positive PW or a negative pH. And then for T2, it's either going to be a positive PW or a negative PL. And then you can also see the delta T equation that I previously mentioned.
So before we can go and actually try to run some results with those equations that Kristen just talked about, we had to estimate a few parameters. So in particular, we estimated beta, which is our force of transmission, and then phi, which is the rate at which diseased individuals become colonized. And this was done with ordinary least squares methods. And the data that we were working with to do this came from the CDC's Emerging Infections Program. So over a period of 11 years, in 8 different states, they collected month-by-month totals of long-term care facility onset C. diff cases, as well as total population in each age group. So we were able to use these to try to estimate those parameters that were either difficult to find in the literature, or the values that we did find didn't necessarily match with sort of the proportion of results that we were expecting. So having estimated those parameters, then we were able to actually run our baseline results. So what you're seeing here is a 100-day simulation of a 40-person long-term care facility. And we've split the 7 classes up into 3 different graphs. So the top one is showing susceptible and colonized, the middle diseased and quarantined, and then the bottom is the contamination level. So that's the pathogen carrying classes. And what we can see is that all classes are fairly quickly reaching a steady state, and in particular, we see a steady state of rather low transmission. So if you look in that the middle graph, which is diseased and quarantined, you can see that over the course of those 100 days, we're expecting about a little less than 1 disease and quarantine individual in that 40-person long-term care facility. As for contamination levels, what we can see is that the highest contamination, so that's CFUs per centimeter squared, so density, is in the low traffic areas, followed by high traffic areas, and then healthcare worker hands having the lowest spore density. This is interesting when we compare it to the baseline incidence, which we'll show on the next slide. And so here what we're doing is trying to measure the incidence of colonized and diseased, and then colonizations due to different sources per 10,000 resident days, which is a common unit for incidence used in healthcare. And what we can see from this is that first and foremost, the most significant source of new colonizations comes from interactions with other colonized individuals. So if you recall from when we showed the schematic, there are 5 different pathways that from which new colonizations arise. So we're able to quantify the impact, again, with colonized interaction being the most significant one. This is perhaps somewhat of an unsurprising result because colonized individuals are just in the long-term care facility behaving as normal. There are no measures that have been put in place to try to limit their spread. And then our second most significant source of transmission comes from healthcare worker hands. So if you recall that in the baseline results, we were seeing that healthcare workers' hands had the lowest spore density, but they have the second largest contribution to new colonizations. The reason for this is because of just sort of the weighting and the frequency of interaction between healthcare workers and residents, in addition to the amount of spores transferred in comparison to how often residents are interacting with those low traffic areas and how many spores they're going to pick up from them.
So after we looked at our baseline results, we then decided to run a sensitivity analysis, kind of looking at how varying the parameters in our system affects the outcomes. We completed this using methods in Marino et al., and we used partial rank correlation coefficients, or PRCCs, to index the sensitivity of each parameter that we're looking at. We also looked at 6 different incidence cases. So as you remember, we were looking at the incidence of colonizations due to contact with high traffic areas, low traffic areas, and healthcare workers, as well as colonizations due to contact with other colonized residents, due to contact with diseased residents, and then just the incidence of diseased. This is our PRCC values. As you can see, a lot of the parameters in our model showed up as having a significant PRCC value. And the main thing to note here is that the closer a PRCC value is to the absolute value of 1, the more significant that value is. And a negative PRCC value implies a negative correlation. So as the value of that parameter increases, the incidence decreases, and then a positive correlation is implied by the positive sign, where as the value of that parameter increases, the incidence increases. But on its own, this big table doesn't quite tell you which parameters specifically are the most impactful to our incidence. And so to look at that, Kristen is going to tell you about a pairwise z-test that we ran.
So in order to determine which parameters were the most significant, we had to complete a pairwise z-test. And so here are the first 3 incidences. As Priscilla said, there were 6. And this table ranks them from at the top being the most significant parameter to the least significant as you go down in level. You can see that for each of the tables, there's a positive PRCC side and a negative PRCC side. And as Priscilla said, that indicates the correlation of the values of the parameter. And then you can see that each table is relatively the same for the incidence due to our pathogen classes, pH, PL, and PW. But one thing I'm going to point out is sigma. Sigma is the spores of pH and PL removed due to disinfection. And you can see that it's the highest and on the negative PRCC side. So as those proportion of spores removed increases, then the incidence will decrease. On the next slide, here we have our last 3 incidences. So we have the incidence of colonized due to interaction with other colonized, and then due to diseased, and then just the incidence of diseased. Something you can see, especially in the incidence of diseased, is that there's a lot of parameters which are side by side to one another, and that indicates that the parameters aren't significantly different from one another. And then to point out one more parameter on the incidence of C due to C and due to D, phi is one of the topmost parameters on the positive PRCC side, and phi is our disease rate going from C to D. And so as that disease rate increases, so does the incidence.
Great. So now with all this sensitivity analysis, we started exploring different parameters and seeing how we can potentially propose different mitigation strategies. And the first thing we kind of targeted was quarantine. And if you remember in our model schematic, that is represented by size. So it's going from the disease to the quarantine class. And we increased our parameter value by 50% above and then 50% decrease as well. And we just saw its impact on the incidence of colonized and where the sources were coming from. And one thing I just wanted to note is that increasing our quarantine rate led to a reduction, and also decreasing our quarantine rate resulted in an increase in the incidence of C. However, we can see that decreasing our quarantine rate resulted in almost a 14% increase in the incidence of C, while on the other hand, increasing our quarantine rate only led to roughly a 5% reduction. So we can just tell immediately that reducing quarantine rate has a very detrimental impact and has a much larger impact actually on the incidence of C. So as a result, we really strongly recommend assisted care facilities and long-term care facilities in general to avoid decreasing their quarantine rate and, if possible, instead increase it by doing more testing at a regular basis. So the next thing we kind of explored was disinfection, and Kristen kind of touched upon this in her sensitivity pairwise Z test. And two parameters that we wanted to explore was mu, which is our weighting constant, so for more cleaning in these high traffic areas such as cafeterias and common rooms, and sigma, which is the proportion of high and low traffic area spores removed by disinfecting. Here we have the numbers and the color corresponding to the colonized instance. And we've also marked the baseline by the gray box in the middle with the 9.23. So we can see in general, increasing both mu and sigma resulted in a decrease in the incidence of C. However, from the gradient, we can actually conclude that maybe sigma has a slightly bigger impact on reducing the incidence of C. So we recommend long-term care facilities to actually focus equally both in low traffic and high traffic areas. So rather than just cleaning the cafeterias and common rooms, making sure to clean these both areas because they both contribute an amount to the incidence of colonized. So the next thing we kind of explored is antisocial level and then healthcare worker to resident ratio. As you can see immediately from this colorful heat map that's very stratified across antisocial level. And higher antisocial level means that residents are less likely to interact with each other. And here again, we have the same color and the numbers denoting the incidence of C, along with baseline marked by the box. We can see here that a higher antisocial level significantly decreased our incidence of C, while a higher ratio of healthcare workers to residents across all the antisocial levels had a beneficial impact in reducing the colonized incidence. We understand that we cannot recommend these facilities to terminate all these social activities because that goes against the whole idea of what a long-term care facility should be. However, this is important to keep in mind during times of outbreak. So the next thing we kind of explored was soap use and hand washing compliance. Soap use is very important when we're looking at C. diff because soap use removes roughly 90% of spores of C. diff, while alcohol-based hand rubs only remove 20%. Furthermore, in long-term care facilities, the baseline hand washing compliance is roughly 17%. So it's very low. So these are two areas that need a lot of improvement. So we increase both of these values, and we can tell that increasing the frequency of soap use along with increasing our hand washing compliance helped us significantly reduce the incidence of colonized. Based on the gradient, you can tell that hand washing compliance seems to have a slightly bigger impact on the colonized instance. However, we strongly recommend long-term care facilities to pursue both higher hand washing compliance and also more soap and water use in general.
One of the last mitigation strategies we looked at was screening. So, if you remember from the heat map Natsuka showed us, the antisociality parameter had a pretty big effect on the transmission of the disease in the long term care facility. So, we were interested in that. And we also know that a lot of the disease transmission is coming from our colonized residents. So, we decided to test the idea of screening on our long term care facility. So we decided to run some results to see what it would look like to, on a weekly basis, sample 5 residents and screen them to see if any were asymptomatically colonized and quarantine the colonized individuals. And then we have results from doing 100% site-wide testing on the facility and, of course, isolating the colonized residents. So one thing that we can see is that it provides some promising results. If you only sample 5 residents and quarantine the asymptomatically colonized, it reduces this number from 9.23 to 7.28. And then 100% site-wide testing on a weekly basis reduces it to 2.3. So pretty low. We can also see that healthcare workers are the second contributors after colonized interaction, which is consistent with what we're seeing everywhere else. Finally, for some conclusions, we essentially are observing that most of our colonizations, again, are coming from interactions with asymptomatic individuals. We also strongly recommend not decreasing the quarantine rate, as Natsuka showed us, that has a detrimental impact on the disease transmission. We also would recommend increases in hand washing compliance, and have observed that more compliance does seem to be more impactful than soap and water usage, but again, both are good. For future work, we're thinking about considering recurrent infections in our model structure, since this is an issue that is prevalent with this disease. And we're also considering connecting this long term care model with a hospital or community model to get a wider understanding of how this disease transmits across different environments. We want to thank the NSF for funding our research and ICERM, and of course, Dr. Sulyok and Dr. Stevenson, and Austin and Matthew, our TAs. And we are open to any questions. Thank you so much for listening.
Awesome. Thank you guys so much. Yeah, now we can open it up to some questions and discussion. So feel free to ask any questions you have.
So the first question that comes to my mind is how applicable do you think this model would be to other types of surface transmittable pathogens?
Could you repeat the last part of your question?
Yeah, so like you have this model, and I think it's a very interesting model. But it's like you specifically tested on this single pathogen, the Clostridium. I'm like very bad at like pronouncing this, but like this specific pathogen. But I think like in care facilities, there's like more or different surface transmittable pathogens you might be concerned of. So I was wondering like how like generally applicable do you think this model is?
I think I think yes, for the surface transmittable pathogens, I think it would be applicable. I know that when we were in the earlier stages of doing the research for this, we were also looking at MRSA and other diseases in long-term care facilities that have similar routes of transmission. And so I believe that you could use a model like this to look at those types of diseases. But yeah, I think the routes of transmission are probably like the main thing that you would want to um, see if that's similar, because a lot of what we did with this model was kind of focusing on how the disease is spreading,